we move to clinical evaluation, in-depth clinical evaluation of chronic enteropathies, just to mix a little bit the topics, it will be more interesting for the audience. Let me introduce Tristan Méric, who's an associate professor at Oniris Vet School. She's an internal medicine specialist, and she'll talk about his work about the well-known clinical score CIBDI and CEPCAI.
Thank you, Juan. So I will just upload. Perfect. So, good morning, everyone. I am very happy to share with you some, I think, very interesting results today about the repeatability and reproducibility of the two clinical scores, CIBDI and CEPCAI. But first of all, what are CIBDI and CEPCAI? So these are two scores assessing the clinical activity of dogs that suffer from chronic inflammatory enteropathies. And the authors that developed those scores chose the items that compose the scores based on literature, but also on their experience to reflect the clinical status of a patient. And they found that the CIBDI correlated with histological severity and that the CEPCAI correlated with prognosis. To enter more in detail into the scores, the CIBDI is composed of 6 items: activity, appetite, vomiting, stool consistency and frequency, and weight loss. And all these items are scored based on the severity, and the CIBDI is calculated based on the sum of these item scores. These scores has since its development been widely used both in clinical practice and also research. As you can see here, a total of 71 studies mention the score so far. The CEPCAI is an extension of the CIBDI. It contains the same first 6 items than the CIBDI, and 3 additional items: albumin levels, ascites and peripheral edema, and pruritus, and still scored based on the severity. The CEPCAI has also widely been adopted. As you can see here, it is mentioned in 48 studies so far. But one important question is, are the CIBDI and the CEPCAI repeatable and reproducible? Before answering this question, let's go back to the definition of repeatability and reproducibility. Repeatability is the agreement between 2 assessments that are done by the same observer, here the same veterinarian, but at 2 different times, here, for example, during the winter and during the summer. On the other hand, the reproducibility is the agreement between 2 assessments that are done at the same time, this time, but by 2 different observers, here, for example, 2 different veterinarians. And to answer to our question, we actually don't know if the CIBDI and the CEPCAI are repeatable and reproducible, or I should say that we didn't know, because we did. What would be the consequences if these scores would not be repeatable and reproducible? In this case, we should question our ability to assess treatment effects. And in clinical practice, it could lead to inappropriate therapeutic decision-making. That's important, sorry. And in research, it could lead to altered conclusions and also to collective perspectives. So the objectives of this study were: 1, to assess repeatability and reproducibility of the CIBDI and the CEPCAI; 2, to search for sources of discrepancies; and 3, to assess the ability of specific scoring guidelines to improve the repeatability and reproducibility. To do so, 2 evaluators performed the assessment of CIBDI and CEPCAI using a set of consultation forms twice at 1-month interval. These 2 evaluators were then given the opportunity to discuss together about the issues they encountered to assess some items, and scoring guidelines were developed based on this discussion to try to uniformize future assessments. So these steps constituted the phase 1 of the study. Then in the phase 2, 4 other evaluators, 2 board-certified specialists in internal medicine and 2 general practitioners, performed similarly the assessment of the scores using a set of consultation forms, twice at 1-month interval, but this time following the scoring guidelines. The consultation form that was used was specifically designed for the study. It contains detailed documentation allowing assessment of the scores, including a section describing the progression of clinical signs. And this consultation form was systematically used for all gastroenterology cases at Oniris Veterinary Teaching Hospital until reaching the desired number of assessments. To claim that the scores were or were not repeatable or reproducible, we used both the Linz concordance correlation coefficient, abbreviated Linz CCC, and the graphical method of Blunt-Altman. And we considered that agreement was reached if we had the three following criteria were respected. A Linz CCC superior to 0.81, a mean bias of less than 1, and limit of agreements of less than 1 for isolated items and 2 for global scores. The mean bias and the limits of agreements are determined thanks to the Blunt-Altman method. In the results, you will find for better visualization traffic light, such as this one, here, and the light will be green when the criteria is respected and red if not. And just before beginning with the results, the power calculation, and to have 80% chances to demonstrate with alpha fixed at 5%, CCC of at least 0.81, expected that the expected CCC was 0.91. The required number of consultation forms to include was 40. So let's go for the results. In phase 1, 41 consultation forms were assessed for CIBDI and CCAI, and these consultation forms were filled for 31 different docs. And the values of the two scores covered a broad range, representative of the heterogeneity encountered in clinical practice. And here is the assessment of the repeatability of different items composing the scores in both evaluators 1 and 2. As you can see, all items were repeatable except for stool consistency when assessed by evaluator 2. When combining the first 6 items, the CIBDI was found to be repeatable for both evaluator 1 and 2. And when combining all the items, the CCAI was also found to be repeatable for both observers. When moving now to the assessment of reproducibility, evaluators 1 and 2 were reproducible for most of the items, but not for stool consistency, for frequency and weight loss assessment. And these discrepancies led to CCAI to also not be reproducible, and it was unfortunately the case for CIBDI as well. When the two evaluators discussed about how they assess the different items, they identified the following sources of discrepancies. Regarding weight loss, one of the evaluators used the absolute change in live weight, whereas the other one adopted a more qualitative approach, including, for example, into the calculation the presence of ascites that can falsely increase the live weight, or caloric restriction applied by the owner and that could have increased the weight loss truly attributable to the disease. Regarding stool consistency, one evaluator did an average of the reported consistency over the past few weeks, whereas the other one used the most severe consistency. And finally, regarding the stool frequency, the first evaluator considered that more than 2 times a day was abnormal, as stated in the first publication of the development of the CIBDI, but the second evaluator considered that 2 times a day still remained normal. So to try to uniformize future assessments in the phase 2 of the study, the following guidelines were developed. For weight loss, only the percentage of weight loss truly attributable to the disease should be considered. For stool consistency, an average over the past few weeks should be assessed. And for stool frequency, the recommendation was done to rely strictly on published numbers, meaning that only 1 time a day should be considered normal. These instructions were used in phase 2, where 59 consultation forms filled for 49 different docs were assessed. And similarly to phase 1, the values of CIBDI and CCAI covered a large range. For all items, the repeatability was good for at least 3 out of the 4 evaluators. And when combining the 6 first items, the CIBDI was also repeatable for 3 out of the 4 evaluators, and it was the same for the CCAI, similarly with repeatability for 3 out of the 4 evaluators. Let's now have a look to the reproducibility results. We had 6 pairs of evaluators here that were assessed. And what you can see is that for vomiting, stool consistency, stool frequency, weight loss, but also pruritus, at least 2 out of the 6 pairs of evaluators were not reproducible. These discrepancies led the CIBDI to be not reproducible for 4 out of 6 pairs of evaluators, and similarly, it was the same for the CCAI. So I assume that this is roughly what some of you might have took away from the results, and I understand it perfectly well, but no worries, we will summarize important findings in the discussion. So first and most importantly, the overall reproducibility was unacceptable. And to be more precise, the inter-evaluator disagreement frequently exceeded plus or minus 3, which means that a same consultation form was given a CCHI score, for example, of 3 by a first evaluator and of 6 by another. And on the other hand, the repeatability was globally good, and taken together, these findings strongly support, whenever possible, that a unique evaluator assesses the same dog twice in clinical practice, but also for research settings. Moreover, the repeatability was overall good, okay, but remained imperfect. In particular, stool consistency and frequency were frequently sources of intra-operator disagreement, even after application of scoring guidelines. One solution that could allow to erase some of this variability in the future is the use of digital tools. Just imagine having to shoot the faces of your dog on a daily basis, and then an artificial intelligence will give you an average of the fecal score over the last 2 months. That could eliminate a recall bias that some owners can experience in practice. But before such tools are developed, we have to account for the imperfection of the repeatability of the CIBDI and CCHI. And the ultra-evaluator disagreement was around 1.5 to 2 points in the results. That means that a unique evaluator can fail to detect a lower change than this value, which can be called the minimal detectable change, or MDC. And it is important that we don't interpret lower change than MDC. That is very important. This invites us to have a look to what previous studies used as a response criteria. And what you can see here is that most studies define a clinical response based on percentages of score reduction. And the problem is that using percentages instead of absolute scoring changes is that the minimal detectable change cannot be respected sometimes. For example, imagine you have a dog with a first score of a CCHI of 6, and after the use of a specific treatment, maybe probiotics, he is scored now a CCHI of 4. This is a reduction of 33%, which some would assess as a response. But if it is actually only a 2-point reduction, and this falls into the intra-evaluator variability. So other studies use also a definition of response as a CIBDI or a CCHI inferior to 3, but this does not allow for to catch all clinical improvement. For example, a dog that is first scored a CCHI of 9, then of 5, is improving, but such definition will not catch such improvement. So this leads us to propose a new standard for response definition, and the pragmatic framework that is proposed here is that when using a unique evaluator, a delta of at least 3 points per score should be minimally considered if baseline score is at least 4 points, and a delta of at least 2 points per item this time should be minimally considered when baseline score is strictly inferior to 4. And when multiple evaluators are used, which we do not recommend again, this time a minimal delta of 4 points per score should be used if baseline score is at least 5, and a minimal delta of 2 points per item should be used if baseline score is slightly inferior to 5. And we believe that such considerations could be of interest for the next version of the consensus statement on the diagnosis and treatment of chronic inflammatory enteropathies of the dog. One last point that I found very interesting to consider today is that we found a minimal detectable change, which is a true clinical change, but being true does not systematically means that it truly matters. And one other value that remains uncertain at this point is the minimal clinically important difference, abbreviated here MCID. And since a video is worth 1,000 words, here's one I found particularly interesting to share with you on this topic.
Hello, I'm Hannah Sachs, Editor-in-Chief of NEJM Evidence, and this is StatStat. You're considering a phone upgrade. The latest model promises significantly better battery life and sharper photos.
Wow.
The ad almost has you convinced, but then you notice the fine print. The new model has a battery life that is, on average, 15 minutes longer than the old one, and just a few more pixels. Maybe those are measurable differences, but would either of those changes make a difference in your life? This question, whether a difference that is statistically significant is also clinically meaningful, comes up in research all the time. Before a trial is launched, investigators conduct a power calculation to determine the sample size needed to detect a predetermined difference between groups, with a predefined type 1 error, or alpha, usually 0.05. When the results come in, investigators look to see if the observed difference between groups is statistically significant, a p-value less than 0.05. But that doesn't necessarily mean that any such difference is clinically meaningful. Addressing that question requires an understanding of what's known as the minimal clinically important difference, or MCID. The MCID is the smallest change in an outcome measure, say the difference on a point scale or difference in survival time, that would be perceived as beneficial. It's about whether that difference matters to patients, or clinicians or health systems, depending on what's being studied. Let's talk through an example. Consider a randomized placebo-controlled trial testing a new medication that aims to slow the progression of dementia. The trial randomly assigned older adults with mild cognitive impairment to receive either the new drug or placebo. The primary outcome is the mean difference at 2 years from baseline and performance on a cognitive scale, with scores that range from 0 to 100, with higher scores indicating better function. When the results come in, patients in the new drug arm had a mean change of -3 points, compared with a change of -5 points for patients in the placebo arm. This difference is statistically significant, but you think it seems unlikely that a 2-point difference on this 100-point scale will be noticed by the person or their loved ones. But how do you know? That is, how is the MCID established? There are different methods to determine this threshold. Let's talk about 2. First, the anchor-based method. This involves directly asking patients or caregivers about their perceptions to allow investigators to see what magnitude of change correlates with a patient being, say, a little worse or a lot worse. For a cognitive function scale, investigators could consider surveying caregivers and family members to assess what change on a 100-point scale correlates with a noticeable difference in a patient's memory or level of independence. An alternative is the distribution-based method. This approach uses calculations based on the distribution of the data, such as taking half a standard deviation of the baseline measure or using the standard error of measurement. These methods provide a data-driven estimate of what might be a meaningful change, but don't directly incorporate patient perceptions. Clinicians and investigators often combine elements of these approaches, using patient reports, clinical judgment, and statistical estimates to settle on a threshold that's considered clinically meaningful, and then becomes agreed upon in literature. Say, an 8-point difference on that 100-point cognitive function scale. Importantly, the MCID is context-dependent. That same 8-point difference might not apply to a related but different cognitive function scale, or to a different population, say of patients with no cognitive impairment at baseline. With this MCID in mind, you go back to the sample size calculation and see that the trial was powered to detect an even smaller difference. Larger trials can generally detect smaller differences with more narrow confidence intervals. So if investigators design a trial with very large numbers of participants to find a tiny difference, they might identify statistically significant differences that just are not clinically meaningful. We want a meaningful difference, not just a statistically detectable one. So back to your phone upgrade. You think it through, survey some friends, and realize that any change in battery life would have to mean a big enough difference to get you through your entire clinic day without needing to recharge, from its current 7.5-hour battery life to 9 hours or more. So the 15 extra minutes is way below the MCID. No upgrade for you. For now, you'll have to keep bringing your charger to clinic.
So I thought that was very interesting, and we don't know actually the MCID of CKI and CPTI. And just before concluding, 2 limits of the study that I wanted to underline. The first is that we use consultation forms. This method likely has led to eliminate the cognitive bias that binds the owner and the clinician during a reconsultation. And this invites us to consider that in real life, in clinical practice, variability could be even higher in our study. Also, you might have noticed that scores were different between phases 1 and 2, and this prevented us to truly assess the benefit brought by the scoring guidelines that were developed. And if you are interested in more details about this study, just so you know, it was published in a veterinary quarterly journal a few months ago, and you can download the paper here using the QR code. And I would happily now answer to all questions you might have. Thank you for your attention, and welcome to Nantes.
Thank you. Very, very fascinating. I have a question about the repeatability. Completely ignorant question. How likely is it if you see the same animal that you will remember your prior diagnosis, basically having already primed yourself to give the same assessment? So basically that the repeatability is something that is like a given.
Yes, this is what we ask ourselves when we want to design the study, because ideally we want it to be more close to the real life situation, and assessing repeatability would have meant that we would have assessed the same dog, the same day, twice, but this is impossible because we cannot be repeatable because the situation is not exactly the same. So this is why we chose to perform the study using consultation forms, to have the same consultation forms, so the same informations, and no cognitive bias linked to the relationship with the owner, and to assess the same information twice at 1 month interval.
Thank you.
Welcome.